Hi, I'm Dr. Giuliano Lo Bianco. I come from Italy. I'm the head of the Analgesia and Percutaneous Surgery unit at Fondazione GU in Cefalù. And today we are going to talk about how to prevent complication of interventional pain procedures. This is my disclosure. So I come from the beautiful Sicily. This is a picture of the Cathedral of Palermo, and the famous Gulf of Mondello is a lovely place where you stay a couple of days or a weekend. So this is our agenda. Let's start from the introduction. These are very good books and is very full of useful information for who is interested in the topic. And two of my last publication is a 3-part narrative review focus on safety and complication of interventional pain procedures. Part 3 is coming out soon. So there is a recent significant increase in image-guided interventional pain procedures, and an increase in the number of complications related to these procedures has also been observed, from minor to severe complication. So then, to ensure the safety of interventional pain procedures, we have to focus on physician expertise and patient selection criteria and patient preparation, and also regular training and regular education and interventional certification, and a multidisciplinary team can avoid and reduce the risk for complication, and also a balance of potential risk and benefits of each procedure is very important, and carefully consider the individual patient's medical history and risk factors. So we are going to focus about spinal cord stimulation mainly. We know that there are several complications, several types of complication. We must be aware of them and try to avoid them. But if not, we have to correct them. So this presentation is mainly done thanks to these guidelines and publication, which all of us should follow. So we have 3 different kinds of complications regarding SCS. One is biological complications, such as immunologic reaction, for example, dermatitis, granuloma, or foreign body reaction, seroma, or hematoma, or infection with a prevalence from 3 to 5%, and also neurological injury and postural puncture, headache, wound, dehiscence, and visceral injury. And also we have this tolerance with the reduction of the benefits from the implant of SCS implant, and the tolerance can be because of fibrosis of the lead or the pain perception, which is changing over time, and also neuroplasticity and hardware-related complication. So, which is mainly because of lead or catheter migration with a prevalence from 13 to 15%, or lead catheter fracture, and IPG-related problems, such as the Twiddler syndrome, which is basically when the patient is slipping the IPG, or pocket pain, which is also quite common, charging problems, battery failure, and programming problems. And also we have, as I said, this lead migration, which is quite common complication related to SCS. And also, it doesn't really matter if we are using an 8 contact lead or 12 contact lead or 16 contact leads, and also can happen even in the most experienced end. And we have the infections, which can basically into the SCS part where the midline incision is, or into the IPG pocket, and sometimes the IPG can come out from the skin. So how can we avoid complication? First of all, we have to focus on the neck guidance and with a risk reduction. So operator skills is very important, and SCS should be indicated only after failure of the common medication or prior to repeat surgery or long-term opioid prescription. Also, trial with a proper interpretation is mandatory. Well, there's still a debate on this, and the psychological evaluation within a year before SCS is mandatory to avoid and to prevent complication. And also, will the bridge anticoagulation therapy, implant the SCS in a sterile environment, such as operating theater, and a traumatic needle placement with a judicious use of force when placing the percutaneous leads, and good hemostasis. And in case of suspected hematoma, an immediate neurological evaluation and an urgent CT scan is mandatory. So the preoperative planning is very important. First of all, select the indication correctly. So patient selection criteria is fundamental. And also optimize the general health and rule out the contraindication. A full explanation of the procedures, the stages, the outcomes, and also a recent MRI scan prior to perform surgery, and decide the level of entry and the final position of the lead, and also select the right technology, for example, the type of lead, number of contacts, and the type of IPG. And before start surgery, decide and mark the site of IPG placement based on the bony landmarks or body shape. So we have these perioperative problems, and we can divide into anesthesia-related or patient-related, such as inability to access the epidural space or reach the right target, or inability to steer the lead to the desired target and side, or inability to obtain the desired concordant paresthesia. Or we can have epidural vein puncture, dural puncture, hematoma, or nerve or spinal cord injury and infection. And of course, the technology-related problems such as lead distortion or fractures, the malfunction of the screener, and connection failure. So these are some tips related to the intraoperative issues. For example, the anchoring. The anchoring is very important to avoid lead migration. So first of all, we should follow the manufacturer's direction and use an anchor to the deep fascia, and using a non-absorbable sutures, and consider the mechanical anchor. Of course, a surgical or a single-stage trial is considered to be safe, more safe, related to the surgical site infection. And the incision, well, it doesn't really matter if you're using a transverse or vertical, does not affect the postoperative outcome. And we have these Langer lines, which is not a must. We can follow the Langer lines, but it's not a must. But making the incision as small as possible to start, and then extending the incision as needed. This is the most important thing. And of course, the tunneling. So the trocar should be inserted into the pocket at the level of the floor of the pocket, not in the middle of the subcutaneous tissue. And also, bend in the shaft will allow the operator to easily rotate the device and palpate the tip of the trocar to ensure the appropriate depth, and create a smooth angle to the pocket for the lead, and create also a loop of the electrode into the midline incision where the lead is. So these are the 4 pillars regarding a tissue dissection. First of all, proper handling of instrument. And of course, the understanding of the tissue planes. The operator should have skills of suturing and knot tying, and appropriate tissue handling and wound management. So in the postoperative care, we can divide the immediate, we can have a wound, the dehiscence, swelling with infection, seroma, hematoma, or hygroma, and any other signs of infection such as redness or fever or nuchal rigidity should be very important to focus on this. And also we can have headache, which can be because of postural puncture headache or meningitis, and of course inadequate coverage, of loss of coverage, or discomforts, or aberrant stimulation. In the long term, in a postoperative care, it is very important to train and educate the patient and the family as well regarding the use of the programmer and the charging of rechargeable devices, and the instruction to avoid proximity to strong magnets such as the scanners, and of course during surgery, avoid monopolar and use bipolar diathermy for any other surgery, and try to avoid neuroxanal analgesia or anesthesia when it's possible. Talking about surgical site infection. So surgical site infection is an infection in the region of an implantable device within one postoperative year, and 80% of cases is from body's own flora, and the majority of cases is in the pocket compared to the lead, with incidence from 4 to 10%, and we can divide superficial surgical site infection is where the skin or subcutaneous tissue and occur within 30 days after the operation, or the deep, soft tissue with muscle and fascia and epidural space within 1 year. In most of the cases, because of Staphylococcus aureus and coagulase negative staphylococci with Escherichia coli and Pseudomonas aeruginosa, less common. So, first of all, regarding surgical site infection, we have patient-related factors such as pre-existing infection or patient population with risk factors, so for example, patient with diabetes. And surgical preparation and preoperative planning is very important, also as surgical and operating room management, antibiotics, the asepsis and sterile dressing, and a meticulous technique with reduced operative time. In fact, the contributors, the risk factors to infection are the duration and the complexity of the lead implantation procedures, the use of a percutaneous lead, and the trial duration. So, the infection management practice. So regarding the preoperative time, we have to decolonize against MRSA, or use preoperative antibiotics for neuromodulation trials and implants with a weight-based antibiotic dosing and with an appropriate preoperative time, such as 1 hour to 30 minutes for using, for example, cefazolin, and remove hair just right before the surgical procedures. And of course, once again, we can use cefazolin. Usually is the most common used. Cefazolin 2 grams 30 minutes before the incision, or you can use clindamycin or vancomycin if the patient is allergic. During the intraoperative management, so we use alcohol-based for antiseptic agent, for preoperative skin antiseptic agents, and if chlorhexidine is contraindicated, we can use alcohol-based solution of povidone iodine. And if you're using an in-cheese drape, then a iodophore impregnated drape is recommended, and also a laminar floor for filters, and of course limit the procedure room traffic. I mean, operating theater during a CS implant is not a party. And just one statement regarding a postoperative time: do not continue antibiotics into the postoperative period for implants trials or second stage implant for more than 24 hours. Well, I know there are some colleagues, some doctors that I keep on prescribing antibiotics even for 1 week after implants. In this case, we have this one statement: do not continue antibiotics beyond 24 hours. So one of the most feared complications is the epidural abscess, with a mortality is quite high, from 10 to 23%. We have 4 phases, which is phase 1 with backache and local tenderness. Phase 2, we can have radicular pain, fever, neck stiffness, and rigidity, which is occurring 48 to 72 hours later. And this is basically when we have to plan something, to do something regarding the epidural and treating the epidural abscess, such as a CT scan, or we know that is the epidural abscess need an emergency evacuation after the diagnosis. So phase 3, in fact, is motor, sensory, and reflex depression, and phase 4 is paralysis. So bleeding risk. The risk of epidural hematoma is 0.3 and paralysis 0.03, and bleeding can occur from placement of the needle or placement of the lead, or the IPG placement also can occur during the removal of the lead or the needle. So hematoma can give from mild discomfort to significant pain and can lead to wound dehiscence and potentially can act as a nidus for infection. So which are the recommendations to reduce bleeding? First of all, identify the risk factors and address in the perioperative period. So every time we have to balance pro and cons, so using stopping the anticoagulants or not. So the NAC recommends a minimum of 5 half-life interval between discontinuation of any of the new anticoagulation before an intermediate or high-risk procedure such as SCS. So another quite common complication is postural puncture headache, so which prevalence between 0.2 to 3%, and not everybody gets headache, so less than 1%, and sometimes can be severe debilitating headache with the persistent leak of and intracranial hypotension with cervicalgia, diplopia, and photophobia. And the prevention is basically be careful, and the management is you can decide to abandon the procedure or select a different level of approach. Use fluids and anti-inflammatory drugs and bed rest, and if the patient is still having some symptoms, a blood patch is what you have to do. So one of the most feared complications is the spinal cord injury, which can give hypoesthesia to irreversible neurological deficits. The potential causes are direct trauma, ischemia, compression from bleeding or device volume, infection, dural puncture, or other iatrogenic mishaps. And injury may occur due to needle placement, the introducer placement, lead placement or manipulation, and lead removal. So again, one of the most common complications is pain related to the device component, and pocket pain it's quite common, where prevalence from 0.4 to 25%. So the predisposing factors are the size of the IPG and rechargeable batteries, and the size of the patient also. The management is topical, lidocaine cream, or other anti-neuropathic drugs, and in case of still patient is presenting pain, a surgical revision with change the side of the pocket of the IPG is mandatory. So what are the conclusions? So first of all, the physician training and credentialing is very important, and also proper patient selection with patient selection criteria is very important to avoid and to reduce a complication. Also, patient assessment and optimized comorbidities, the informed consent, procedural precision, and medication management with a vigilant post-procedure care and emergency preparedness. Always follow the guidelines based on the best available evidence and expert consensus. Thank you.